We will begin in approximately 5 minutes. Thank you. This is Mike Gagnon, founder and CEO of the Academic Orthopedic Consortium. We appreciate you dialing in. We will start in just a couple of minutes. I have it as 7:31 Eastern Standard Time. We know people are coming from different things, and we've got a lot of West Coast folks joining us. So we will start in just a couple of minutes. Thank you for your patience and welcome. Thank you all for joining us this evening. Welcome to what is going to be a double feature webinar tonight, a WebEx. We're delighted to have a group and then an individual. And so I just want to thank everybody for joining us again, for taking time out of your schedules. There's a lot that's going on. Also, a turnover of residents and fellows coming into programs. So it's a busy time of year for all of us, juggling a lot of things. So we especially appreciate the time that we have together this evening. I'm the founder of the Academic Orthopedic Consortium, which is think of it as a company that provides best practice in business and leadership to 125 university-based orthopedic programs across the country. And what you're seeing here is a slide that shows, I think, nearly all of those programs, and we have approximately 1,000 members now. 450 of those are actually residents and fellows, and this is our management team, and we're delighted to have some terrific leaders who are some of the most seasoned and experienced academic administrators that we have in the country, who really help us to provide so many different programs to all of the members and the institutions across the country. It's our 15th year in existence, and we're very proud of what we've been able to do, and especially as it relates to providing meaningful and timely information to chairs and administrative leadership and faculty since COVID broke mid-March. So some of the speakers that we're going to have this evening are really going to talk to us about what this all means and where we think it's going. I'm especially grateful at this time because the basis of this company is not based on membership fees. We don't charge membership fees. We don't charge to do analysis or benchmarks. And the way that all of this is supported is through sponsorships that I'm able to identify and negotiate, and then we just subtract the expenses of running everything and doing all of this stuff. And what's left over is how I support myself and provide stipends to the team. So we're very grateful for everybody who is joining us. And I just wanted to, suggest a couple of ground rules here before we go forward. Is to suggest that if you want to ask questions, this is terrific. This is supposed to be a live engagement where we will hear from speakers, and then at the conclusion of their talks, we will take questions. And the way to do that is that if you move your cursor down, you will see a little bubble, a cartoon bubble, and when you put your mouse over that, it says chat. And it's through the chat function that we want you to send questions, and we encourage you to do that. So the folks who are here tonight are just not really here to talk to you, but to talk with you conversationally. So please use that chat function to take care of questions. I want to introduce our first group tonight. It's the co-founders of Orthomentor. Orthomentor is a fabulous company that was started just a few years ago by 3 orthopedic surgeons who really are extraordinarily passionate about mentorship, the relationships we have one to the other, and how we all can lift each other up through these relationships and understand each other better. And through taking insights and feedback and questions and concerns, I think that this group has done an extraordinary job to develop solutions to problems and to crowdsource and develop a think tank. And they have really got lightning in a bottle, 6,000 followers. So it's kudos to them. So the 3 faculty members that we're going to hear from this evening, orthopedic surgeons, all of them, are Dr. Iyer, called Tabs. He's the chief of foot and ankle surgery at the University of Miami, and he's one of our presenters tonight. We also have Dr. Jonathan Kaplan, who is an orthopedic surgeon and fellowship director for foot and ankle at the Hoag Orthopedic Institute in California, Irvine. And then we have Dr. Matthew Varicallo, who's an orthopedic surgeon specializing in sports medicine and total joint in the Penn Highlands healthcare system. And he's also a team physician for a team in the North American Basketball League. He does look like a UFC fighter. I'm just going to give you a heads up. And he's got 875 pairs of Air Jordans behind him in what looks like a paneled wall. I think we're going to be able to pick him out of our lineup. Secondly, before I hand off to that group, but certainly not least, we have an interview with Dr. Zeev Kain. Dr. Zeev Kain is an extraordinary visionary and somebody who's been, he's a founder, president of the College of Perioperative Medicine. He's had, interactions with presidents of the United States, and some of his work and some of his meetings are, quite honestly, some of the best meetings in the country. And I hear this from so many people who are in the upper echelon of what they do in healthcare, who really, just chat these meetings up and look forward to them all year. So we're delighted to have Dr. Kane, and I'll give him a more proper introduction later on. But at this point, I'm honored to hand the baton off to Dr. Jonathan Kaplan, who's going to take it from here in his presentation, which is entitled, and I got to tell you, you can tell these guys are a little bit academic. This is a long title: Paradigm Shifts in Advising, Mentorship and Orthopedic Surgery. I'm not done yet. Accelerating the Modernization of Mentorship During the COVID Pandemic. So thank you so much, Jonathan, Matthew, and Tabs.
Thank you very much. I'm going to share my screen. Just want to confirm, are you guys able to see my screen okay?
Yes.
Perfect. So thank you very much for the kind introduction. You laid out the long-winded title that sounds fancy, and just wanted to be able to give everyone who's on here a little background as to what we do and our thought process before we get into the discussion. So the question is, why is mentorship important? And what we've realized, it's really a bi-directional value. There's value to the mentor and the mentee that provides longitudinal relationships. There's career satisfaction, both for the mentor and eventually the mentee. And for those of you who are here representing your institutions, there's value, extremely important value within your institution. Provides opportunity to build a research platform, to expand your reputation, and having mentors and mentees allows you to identify potential future residents and future faculty members and really vet them in a positive way. We realized in Orthomentor a few years ago that there's really a void in mentorship, and this is not necessarily unique to healthcare. A lot of times we'll ask ourselves, do we have a mentor? And within healthcare, there's a lot of uncertainty. 54% of people say no. Interestingly, 9% say maybe, meaning they don't know if they truly have a mentor. And if we look at all the advanced industries, healthcare really comes in very lowly at only a 43% rate of having mentors. And so that led us to Orthomentor. And a lot of questions we'll get is, who or what exactly is Orthomentor? And it's a group of physicians that are trying to really revolutionize the concept of mentorship. It's a multifaceted platform. We're trying to promote advising, mentorship, providing information, particularly for medical students, connecting faculty in order to improve the world of mentorship. Our mission is really to provide this multifaceted platform and focus on medical students wanting to become orthopedic surgeons. But our vision is really to be able to expand this beyond just orthopedics. We want to establish and cultivate relationships and kind of build a blueprint for mentorship that could apply to all of medicine, not just orthopedics, and even a lot of other professional programs. So Michael was kind enough to give us an introduction on ourselves. The three of us are the founders of Orthomentor, but we really couldn't do this without other teamwork. Dr. Levine, who is at New York Presbyterian in Columbia, Don Laporte, Johns Hopkins, and Kara Cipriano. Dr. Cipriano and Dr. Laporte and Dr. Levine are all part of our advisory board who have really played integral roles in building this platform. We've really worked on a lot of different projects which have expanded through COVID, which is really what led us to this topic today. We started with our Orthomentor platform on Instagram. We do a weekly Insta Live series in which Tabs usually connects with program directors across the country. It allows us to highlight these programs for students who are looking to apply and get more information. We've done multiple webinars, particularly in the time of COVID, in partnership with Columbia University, and we've had anywhere between 1,000 to 5,000 registrants with programs across the country, and even people like Dr. Bonnie Mason from Nth Dimensions, which is a program that really is focusing on underserved and minority students who are interested in medicine. And we also have a podcast, which you can check out on Apple, and we have a blog that we work with for the American Academy of Orthopedic Surgery called Sounds from the Training Room. And all of these are platforms in which we try to really provide information. And so we just wanted to give everyone insight before we got going on the overall topic that we're going to be discussing. But really to focus more on our discussion today, we wanted to be able to talk about what is happening in the time of mentorship. So let me close the screen and we'll go back to our normal platform and we'll have a discussion. So let me stop sharing. Okay, so hopefully everyone can see our beautiful faces at this point. And our thought process with this is we really wanted to give insight into not just how mentorship is important in orthopedics right now, but how is it affected by this COVID pandemic. And just to give some background before we jump into the questions, we don't realize how much in-person interaction has been formed and developed with how we introduce students to orthopedics, how we vet students, how students rotate with us. I mean, medical students have in-services, they have in-person journal clubs, they rotate on the services, they go on away rotation. So these are all things that are in person, which have now been disrupted because of the coronavirus. So those are some of the things we're going to talk about. And I'm going to start with Tabs. I'm going to let you really focus on this question. Tabs, given that away rotations are traditionally important for both students and programs, how are programs adapting to the lack of away rotations within the current pandemic? Tabs, you may be muted.
I'm there. I unmuted myself. I'm not technically challenged, as it may have seemed otherwise. It's a great question. And first off, John, thank you for doing such a wonderful introduction of the platform. We're really honored to be here along with Mike and with Dr. Kane. It really is just a real privilege to have the three of us together discussing these things. With regards to away rotation specifically, the away rotation, so for those who may not be as understanding of it, the away rotation has sort of been really critical for students to have the opportunity to engage with programs in their pursuit of especially competitive residency positions. That has since been obviated with the pandemic. And so students are now trying to figure out how best to network, how best to connect with programs when they don't necessarily have these away rotations in which to do so. So some of the things that are occurring are that, one, programs are spending a lot more time kind of investing in their students and the opportunities that are occurring there. At Miami, as an example, we're giving the students an opportunity to kind of rotate over the course of 3 months in a variety of different electives. And then across the country, there are many institutions, and a couple that come off the top of my head include Columbia, NYU, and Wash U, to just name a few. And University of Minnesota is another one, but there are a plethora of others out there that are developing virtual opportunities. These virtual opportunities do not necessarily replace this away rotation that I have been alluding to or referring to, but what they do allow the students to do is to give them an opportunity to at least engage with the program, engage with residents, and even interact in almost an academic sort of manner, whether it be a journal club, whether it be a conference, or whether it be some sort of didactic that can be prepared for, and then your clinical acumen or academic acumen could be demonstrated. So these are some of the things, just a few of the things that are being done, and is being done in varying degrees across the spectrum of programs right now.
And Matt, going off of that, what do you think are some tools or some ways that programs can really set themselves apart to establish themselves for these potential applicants and future residents?
I think the interesting part with this, and we talk about this a lot of times when it comes to mentorship as a whole, is that there isn't a standardized recipe here. Well, this 100% applies this year because it's such an unprecedented time. There's not a standardized way for these programs to approach this. So I think the ones that are going to be the most successful in terms of jockeying for a position to get the exposure to a greater applicant mix, hopefully on the positive side that obviously the programs would want. I think that more of the outside the box approach that they can do, the better. So you talk about these virtual happy hours. I know we run the Instagram live sessions with the program directors and the assistant program directors. The other thing that I saw the other day, and I just kind of anecdotally am keeping track, I saw a resident from Ohio State, I believe he's a chief resident. He put a tweet out on Twitter and it said, to all the applicants applying this year, if you have any questions about the Ohio State program, feel free to message me. I think that it's going to be that type of stuff. And in many ways, it makes it kind of fun and unique where there's no formula. We don't have data to say, oh, this is how you approach this social media era and how to, access, the potential applicants. There are some programs that, and this is obviously the rare side of it, is a lot of programs, or sorry, some programs, the minority of programs will have such a name that they can kind of sit back and they're going to get the applicants no matter what. That's not the majority of programs, but the programs in the top, the upper echelon, it's certainly going to be that. I think that the interesting thing too is that it's going to give programs that are kind of in the middle tier, the more they can, and certainly, the lower tier, although, each program's a little bit, I don't know how that comes across, but basically the ones that find these unique positions and come up with these outside the box ideas are going to be the ones that benefit the most from it.
And so I'll throw this one up to either one of you, given the fact that we're talking about acceleration of modernization, that's in our title, what value does social media have in helping modernize mentorship during the pandemic?
Yeah, I'll jump on this one. What we're seeing at least just with the last even 3 to 4 months is that there has been a huge shift, a huge number of social media accounts for various programs, as Matt is alluding to, trying and demonstrative of programs trying to figure out unique ways to connect with students in ways they may not have necessarily thought to do before. So while they were probably in prior years banking on those away rotation, interactions and forms of engagement, now you have to really leverage sort of a virtual way in which to connect and discern the various attributes of a given applicant that you're interested in cultivating into a resident. And that, I think, is where the virtual opportunities can play a huge role in that way and may set programs apart. But certainly the ready engagement on social media, as in the Ohio State Chief Resident who Matt just mentioned, that is also an additional way in which to kind of further digitize this notion of mentorship, which we always sort of think of as, hey, in a box of behind a desk in person. And we really have to break or disrupt that concept that mentoring can occur at a variety of different stages, can occur early and should occur early, and now can occur in a variety of different platforms, social media being one of them. And I think the growth that we're seeing is testament to that.
Yeah, I think the points that I would add on with that, and Tabs kind of took my line, disrupting the mentorship game.
Good one.
But that's one of the things that is kind of it's always been in our vision as part of the Ortho Mentor, in our message. We were trying to disrupt the mentorship game because it's not in a vacuum. It's not in a box. It's not, at one point it was this where you're sitting across the desk and you have your student there. And I think in many ways, and Tabs and Kaplan, we've all talked about this, that students a lot of times don't understand the difference between mentorship and advising. There are differences in terms of the phases of. So if you're thinking of advising, how to best advise an MS3 that is about to apply to ortho, there are certain facets you can approach that. We always talk about the difference of mentorship. Mentorship is longitudinal. Myself and Tabs, we kind of have this dynamic relationship that has blossomed over time. I was a medical student, Tabs was my chief resident, and now, we've stayed in touch, and now it's a attending colleague relationship, and we also have this ortho mentor on the side. That is what mentorship is. We'll have students that reach out to us a lot of times, and you can tell that concept isn't well understood, even from the attending side on down to the students. I think to just the last plug that I'll say for the social media side, I think it's really critical. If you look at the wave of how things are going to a more virtual platform across everything, across all of this, the field of mentorship, across the, reaching out to applicants and everything like that. If you look at the wave of education, everything is moving towards this virtual platform, this social media. If you just go onto Twitter and you type in #OrthoTwitter, it'll pop up a bunch of surgeons that are getting advice virtually in this open discussion, free open discussion platform. It's really it's an amazing time to be alive in this unprecedented time. So embrace it. I know there's a lot of anxiety from the students, but just grab the bull by the horns.
And so I'll throw this one out there, kind of going off of that. We talk about traditional programs where you're a medical student, you do research at your home program, and research is a critical component of mentorship and getting into orthopedics. For either of you, how is this advancing the access to research? What are some tools that students have at their fingertips where they can have a larger connectivity and reach a greater network of people?
So I think one of the things that this is really telling us, and I was on the phone with a student interested in internal medicine earlier today, it is really a lesson that everyone needs to learn in networking and networking capabilities. And how do you cultivate that specifically with regards to outreach, with regards to connecting with residents or attendings and so on. And I think that the way in which we can bolster these various relationships is to actually help grow even your research. And that is one way in which you can maintain and grow a relationship into that of what would be considered mentorship with time. So a particular attending or particular resident can actually see your progress with a particular project you might be involved with. So now, John, Matt, and myself are engaged with students across the country in a variety of different research projects to try to push forward this sense or push the needle on how we interact, how we connect, and how we plant those seeds of mentorship, really. So I think it's a super important time for all of us to be able to engage and use social media to push forward our academic aspirations and also on the student side as well.
I was just going to say, so the other thing, you look at this type of time, and anytime there's a crisis like this, there's going to be some sort of disruption to the system, and it's going to shift and pivot to a changing environment. So if I'm a student, this is a very unique opportunity in time where you've had a little bit extra time to focus on these other elements, and also reaching out to these faculty members who are, because of the situation, because of COVID, they are, in my opinion, I think the others would agree, they're more open to this virtual collaboration. At one point it was, no, we can't have you involved. There's too much with the IRB. There's too many, hoops to jump through. I've been working on this remote side of this for a while. I've always looked at it like, why can't a student do a virtual, work on a literature review or do something? It doesn't always have to be you have electronic medical record access at the hospital system and you got to go through all the bureaucracy and everything. And I get there's a point to that, but I think there's been this big gap where students that don't have a home program or they haven't been reaching out to their own orthopedic program or community orthopedic surgeons, I think now has been the time where you reach out to people. I have probably a lot of students that are mad at me because there's still some unanswered emails where I haven't followed up on projects. So hopefully not too mad at me. But this is definitely different than it used to be.
But there is a saying, never let a pandemic go to waste, meaning yes. This is an opportunity to build on the current platform and foundation to take us to the next level.
Sounds like a homework card.
With that, I'm going to pivot because I want to loop in Dr. Zeev Kain because, and I'll give a plug. I had the opportunity to go to his value-based care program that he has annually, and it's one of the biggest, if not the biggest, orthopedic value-based care program. And I think that this is going to be especially integral for not just faculty and orthopedic surgeons in practice, but for residents and medical students to be learning about. And so I wanted to have this opportunity to ask Dr. Kane a couple questions as well. So if that's okay, we're gonna bring you in, Dr. Kane. And this should be right in your wheelhouse, so I don't think this will be too hard. But as we take education and mentorship out of the classroom and the clinics, how do you anticipate incorporating teaching students the business of medicine, the value, we would say, so not just how to make money, but how to make medicine valuable for our patients?
Yeah. So first of all, Mike, thank you for having me. Everybody, it's great to be with you. And Jonathan, you are literally a few miles away from me, and yet we talk to each other on WebEx all around the world. So that's the fun of where we are. Before I address your question, I want to make a comment on what you guys just discussed. Medicine is traditional. We don't change quickly, guys. I hope you know that, especially those of you who have business background, right? Think about minimally invasive surgery, then think about the fact that they fixed airliners 30 years ago with laparoscopic equipment. So I'll just stop there. Now, if you are looking at John Scotter's work, and John Cotter is a business person from Harvard who really talked about change management. And when I was the Dean of Clinical Operations at UC Irvine and the Chair of Anesthesiology, I use his book very frequently. It's called, one of his many books, it's called My Iceberg is Melting. Okay. Now, what does this book basically talks about? That people don't like to change. What a shocking surprise. What's really nice about his book is that he identifies personalities of people all around you, that when you come up with a new idea, there is going to be a response with a variety of responses. I'll stop there. That now is exactly brings us to where we are today. If you look at John Scotter's work, step one, and I'm looking at it right now, and maybe later I'll show the slide, it's called create urgency. If you want to change, guys, anything, including your personal life, if you're not going to have urgency, you're not going to change. That's it. I don't care if it's your working out or, you know, you may be all married, but looking for a girlfriend. So same idea with using now technology for mentorship, right? The tools were there a year ago. Why didn't they use them? Let's just take now that and explode it to education a little bit. And I'll tell you something that drove me crazy when I was chair of a department here. Why do I need to do residence conferences every day at 4 or once a week at 4, when at UCLA, they do the same thing, and in UCSD, they do the same thing, and in UCSF, they do the same thing? I don't get it. Why can't we have just one residence conference, virtual, and all the universities will listen in? And I have to tell you, I tried it, total failure. Total failure. Nobody wanted to log into somebody else's conference. So I think we are a bit chauvinistic. I think we are a bit like we do things the way we do things, and we're not changing. Well, now we have an opportunity. That's how I would treat this pandemic. I like you saying about not waiting or a crisis go to waste. That's how I would treat this crisis, guys. It's a huge opportunity for many things, certainly for education. I personally think it's going to disrupt the way universities deliver education, but that's neither here nor there. We can talk about it later if you want. So certainly now, if we move into the element of how will this impact business, well, it will impact business because as we move into telemedicine, which is one example of what's going on, and just show of hands, can I assume right now that all three of you deliver care now with telemedicine?
Yeah.
There you go. Now, we're going to in a minute, maybe you'll tell me, well, it has its place and it's an amazing place and we don't know what will happen. I accept all of that. I'm not here to say that telesurgery will replace anytime soon. Not going to happen. But all I'm going to say is that it's an example how things are changed from a business perspective. And later on, we'll talk what's going on with your volume of business. And so we now have to find an opportunity, especially when you mentor these kids, they have to understand more about the business of medicine. And by the way, we're all physicians here. Mike, you're friendly. So I can see the smile. Guys, if we're not going to do the business of medicine, somebody else will, right? Yeah. That's just the reality. So I never understood this logic of, well, we'll operate and somebody else will take care of the business side. I don't sure I understand it. They have their place. Mike is the best in operations of orthopedics, but you have to have a fundamental understanding of what it does. And by the way, our conference, which I'll get to later on, that's the unique thing about it. I'm trying to break the silos and bring all the players into one space so everybody can understand about what everybody else is doing. So it's kind of a long answer, but I'll stop here.
No, that's perfect.
Dr. Kane, is one of your passions documentation and coding and the lack of training that we get in that? That's one of my passions. I didn't know that. This is like, it's like we met and we probably were friends in another life or something like that. Yeah. But I've always harped on that. Tabs knows I'll talk till I'm blue in the face. But we trained for how many years? We come out, like when I do the op reports, I put the CPT code right there. We're never trained that stuff. You're never trained that. Instead, it's somebody who goes and takes online classes and watches some forums and goes on to make maybe a webinar or two and learns Oh, I'm getting the notification I should stop talking, but I appreciate that. So I love to hear you say that.
Yeah, well, I think, we have to remember from a business perspective is that, anesthesia has large bills, just like you guys have in orthopedics. And I always said, I can't believe this. My anesthesiologist has just done a 5,000 procedure in the operating room. And now somebody who gets paid $15 an hour is going to determine
Yes,
if we're going to get paid or not.
this is an extreme example, but I know a surgeon who left millions of dollars on the table for an institution because he or she didn't think coding was important. And that's what ends up happening long term. And the institutional viability, financial viability is at jeopardy, at risk. So
That's always true.
Yep.
All right, so I'm going to jump over to Michael, mainly because I think we have, correct me if I'm wrong, I think we have about 5 minutes or so for some live Q&A in case you received any questions. If not, I still have a few more questions, but I at least wanted to open this up in case there were some questions from the audience.
Thank you, Jonathan. That's right. And certainly this is lively. I do have actually two questions that have come in. One from an academic that talks about, mentorship, where mentorship was already a bit broken. And part of that is because we don't, actually, I think the gist of this is suggesting that division chiefs at academic medical centers are traditionally picked sometimes as the oldest person who's in that division, and we don't necessarily equip these folks to provide the mentorship. So how do we address that? The train the trainer sort of thing. How do we build mentorship skills?
I'll jump on that personally, because I'll tell you exactly how things have been at University of Miami specifically, and how in part a lot of what I've done has fueled Orthomentor and what John, Matt, and I have done together. So when I got to University of Miami, there was, at least for the medical student side specifically, there was minimal support, limited support with regards to advising for the medical students, particularly for those interested in orthopedics. On top of that, there was limited mentoring and grooming of said students who may, from an early timeline in their medical school career, may be interested in orthopedics. So when I got here, I noticed this void, and I said, well, I'm going to, there is, as Dr. Kane said, I'm going to create a sense of urgency, and I'm going to change the environment myself, one way or another. And so what now, 5 years later, we now have 18 students applying to orthopedics this year, which is the most it's ever been. I have 17 of those 18 students that I have mentored personally from the time of, or the beginning of their first year of medical school all the way to now near the fourth year. And now, because of the 18, in light of the COVID pandemic, I have an entire department that sees what is happening and the engagement that I have been able to sort of instill and create amongst the students, amongst the residents, and amongst a handful of faculty members that are involved. And that's in part how we've been able to start changing the culture. Many times it does take one person to really light the fire. And secondly, it also takes someone to really demonstrate, particularly at the top. If it's ideal if it's at the top, if it trickles down, that mentoring and advising is important no matter where you are, whether it's for residents, whether it's for faculty or whatever. But I think that I personally, in doing this, have been able to show and kind of create a culture and cultivate a culture that has been much more nurturing of that notion as a result of what's been seen. So it does take just one person, and one person can make a difference in this way, as cliche as that sounds. But I think you really have to just start somewhere, whether you're the youngest person on the totem pole, whether you have a division chief title or not, or no matter who you are. If you think this is important, you got to take it and run with it. Come up with a plan, come up with an idea, pitch it to the folks ahead of you, and try to make it work no matter what.
I appreciate that. There is another question, Jonathan. I don't know if you want to go to yours or if you want me to pose it.
Go ahead, lay that question on us. It's always better to have the live action ones.
All right, here you go. Is VR training a real value in the future or just an interesting tech fad? And this comes from somebody out in the Silicon Valley area.
Matt, you got any comments on this one?
Yeah, actually I do. And I've talked about this a lot with, so I think, again, with the pandemic and the other thing that is going to factor this in, programs, because of step one going to pass fail, programs are going to need to have some sort of objective, quantifiable data to track back on and to see what's going to predict success for students in the future. So we've talked about this. There's going to be some sort of virtual training, virtual curriculum. You know, we talk about this when students enter medical school, they get anatomy for the first 6 weeks. Sometimes it's 8 weeks, sometimes it's 11 or 12 weeks, but then it's done. So I think there's going to be something in that area in the virtual training, whether it's anatomy or knowing how to assist in surgery or demonstrating basic competency that can then predict success, whether it's generating a score from a test, from something like that. And we're talking about medical students that want to go into a surgical profession. So something very hands-on like that. Programs are going to have to rely on some sort of objective number that's going to replace step one, being pass-fail, because that was a big fallback. If you talk about that cutoff there, there's going to be something in the future. So I definitely don't think it's a tech fad. And I'm in Western Pennsylvania.
Yeah, and I would go further to support that. I think that we know that outcomes and skill levels based on volume. And so VR gives the opportunity to provide students and residents with more volume in a safe setting, in a connective setting. And I mean, there are studies coming out that are showing that there's improvement in competency scores and basic surgical skills in students and residents who have access to these types of programs.
Yeah, I think in some ways the bridging the gap there, so it's not a virtual interactive environment, but if you know, we've talked about this, like the resource that ViewMedi is. So when you're watching a video of a surgical approach from a different surgeon who has a whole different approach to something, I learned stuff from that. So I've never trained with him. I've never trained with this individual. I've never interacted with him, but I pick up pointers from that, and that's just watching a video. So I think there's definitely going to be a footprint for that.
Perfect.
Thank you so much, Ortho Mentor, for such a great session. And we are going to be able to push all of this out to our 1,000 members. And I think that, you know, we will be able to bring a lot of visibility to the things that you're doing. And I love what you're doing, because even before the pandemic, I felt like mentorship, certainly on the academic side, was something that's very difficult. And I think that the emergence of the EMR did not help that. You know, as people are working on the keyboards instead of talking to patients and residents and fellows. And this, at some level, sets an example. So I'm really looking forward to what you're doing. I love the work you're doing with all medical students and even undergrads. And we want to bring more visibility to what you're doing. So thank you so much, Ortho Mentor, for everything that you've done to help us this evening. Thank you.
Thank you for having us.
Thank you for having us.
Thank you.
I want to shift now to Dr. Zeev Kain, who's the founder and president of the College of Perioperative Medicine. And I also want to thank his executive director, Robert Stevenson, who is just superlative to work with in trying to set something up, as Dr. Kain's schedule is very busy. But by many accounts, Dr. Kain is a true visionary in the global healthcare space. He's a Yale and Harvard-trained anesthesiologist, pediatrician, entrepreneur, and innovator, and is the chancellor's professor at the University of California, Irvine. And as others have referenced, he truly is somebody who puts on some of the best, most innovative meetings of the year and really poses some challenging questions of those who are innovative leaders. And so sparks fly, and he does a brilliant job of facilitating all of that. So it was our great pleasure to be able to get him to agree to sort of do the open-end interview situation where we can pose questions to him and he'll respond to some of these things. And the timing around all of the COVID stuff has been really very interesting, and I think it's going to set you up for a great conference discussion, Zeev. So thank you for being with us, Zeev.
My pleasure. It's really sounds like a lot of fun, and your own organization has a tremendous influence in the academic orthopedic community. And so I can just wish that we in anesthesiology it's something similar. So if you have a twin brother, talk to me about
it.
Yeah, I'll talk to Robert Stevenson. He's got a lot of game, and I think he could probably develop that. But I want to get to some of these questions, because I know so many of us with children, we're getting ready to make this big decision, you know, school, no school, what to do about it, virtual, online. And this is because of the reemergence of COVID. So just when we thought things might die down or that things might improve with the summer months and this sort of thing, here we go again. The snow globe is shaken up. And so it's timely that we have you here. But in terms of things, when you look at this, Zeev, from a scientific perspective, what kinds of things are you predicting or can we expect over the next 12 to 24 months? And how will these things impact our medical practices?
So that's about a 2-hour worth of question.
Yeah.
But you know, we'll start slowly. And so I actually, before I answer that question, I wanted to share with your audience our website of the American College of Perioperative Medicine. Hopefully everybody sees it right now.
Yes.
And it's fully loaded with conferences as well as resources, presentations on operational, clinical, and financial. We really have started with orthopedics because orthopedics to me has been the most avant-garde and progressive space among all the surgeons. There's really no other way to say that. And so you see now is our 2020 meeting that had about 500 participants and sponsored, by the way, among others, with the hospital of with HOA in Hogue. And Jonathan Kaplan's group and Dr. Jamie Calouette in particular. So, you know, this is the space we feel most comfortable in right now. And that's because it's the space that is really moving the fastest. That's all I'm going to say. Now, if I'm going to now switch from that, I'm going to stop sharing the screen and switch from there to maybe before I start, I should know how to stop sharing the screen. How about that, guys?
Jonathan Kaplan, you jump in. You're the expert. I believe when you move your mouse to the orange section there where you're sharing, you can stop sharing to the left of that.
Yeah, it's either there may be a crossbar at the top that
absolutely. Okay, there we go. So I personally do kind of Zoom all the time, and I apologize for I said I typically do Zoom all the time, but this is an amazing platform. So let's start with the bigger question, and in particular, let's focus on orthopedics because I think that all of us almost getting a fatigue from watching CNN. The one impression I have I don't know when this became a political issue. Okay, I really don't understand when did the pandemic become a political issue? Why is it a political issue altogether? It's a healthcare issue. And I just wish we would treat it as a healthcare issue and just let's agree that we put all the politics on the side. I don't care what your political views are. There are some fundamental facts. In this world, there are viruses, there are bacteria, there are single-stranded viruses. This is a single-stranded virus, period. It's not a Democratic virus or a Republican virus or a Chinese virus. It's a virus. We know how to take care of viruses, so I think we need to move on and just take care of this virus, okay, and leave all the politics alone. Now, I'm also a great student of history. So for those of you, I really recommend to look at the pandemic of 1918 curve. And, you know, when I talk about it, you'll say to me, yeah, but that's 1918. And I'm like, really? And do you know today to better manage viruses than 1918? Maybe, somewhat, but not necessarily amazingly well. So I'm going to say that you will follow the 1918 epidemic or pandemic in terms of the scope. Obviously, I hope it's going to be much lower. So what does that mean? It means we had one wave. It means we're going to have a second wave. That's it, guys. We're going to have maybe a third wave, hopefully not with the vaccine coming in. Now, why did the first wave in the pandemic of 1918 go all the way almost down to zero? Because everybody was synchronized and everybody did everything at the same time and went up together and down together in our country. And I think it's a good thing that we closed down the country You can debate about it, but the reality is that then it differentiated between the various states. And so now you have these various tops and peaks, and so you don't have anymore the big up and down, right? So you flatten the curve, and that's just what we have done. So do I think that we'll have a second wave? Yes. Do I think it's going to be better managed than the first wave? Absolutely. I'm going to ask you to look at the data of mortality. And if you notice, there is almost a 75% decrease of mortality in relation to the number of hospitalized cases. And it's not the two-week interval there. So why is that delta happening? And there are two explanations to it, at least. One is your patient population is younger, so they are less sick. That is true. The second is that we know how to treat it better, honestly, right? We now give dexamethasone. We don't put them on the respirator immediately. We are not causing all these toxic syndromes from the release of interleukins and so on. So I think it's less deadly than it was before. I think you will see a second wave. I think it's going to be less deadly. I hear nonstop about the vaccines, right? We have to talk about that. There was a big announcement today. I don't know. I'm a bit more skeptical, maybe because I'm older. So I'm hopeful for a operational vaccine in the first quarter of 2021, maybe the second quarter. I don't think it's going to be before. It's not. That's my opinion. All my opinion. But if you talk to the people in those companies who are in a leadership position, that's what they'll tell you off the record. So I think that's where the vaccine are or is. Now, operation of hospitals, I think we have learned from the first wave. I don't think we're going to see any more stopping. Well, I hope so. We're not going to just see stopping all surgeries. I just don't think that's going to happen. I think people will understand that you need to continue to run your business and cope with the pandemic at the same time. And you can do it. You really can do it. It's just a question of doing it the right way. By the way, it does include that some of your volume may move to ambulatory surgery center, right? We can talk about it later on. It does move that. It does mean that you are going to do some of it through telemedicine or telesurgery or whatever you guys want to call it, right? So there are changes. But I think that we'll continue to cope with it much better than what we have done before. I'll stop here.
You know, I love your energy. You're very easy to listen to, not only for the way that you intertwine historical reference with data, but also the exuberance you have for it. And it really positions you coming off of a mentorship discussion as somebody that people would just love to listen to you. So I appreciate your time with us tonight, Zeev. Talk to us a little bit about what that means. I want you to take that question a little bit further as it relates to bringing patients to clinic. And I will tell you that from an orthopedic perspective, when elective surgeries were, sort of not happening and patients weren't coming into clinics, that was an extraordinary, financially difficult situation for us. So talk to us about what you think happens there in this next wave. You think that's coming?
Well, the next wave is coming. It's now the question of how you're going to manage it.
Yeah.
There's no question. I think the way you need to manage it is really with shift to, and I'm going to now put in plug to value-based care, which is not everybody likes that term, but that's just the reality. What value-based care really means is to provide the most efficient care. It doesn't mean to pay the least to doctors that you can in the world, guys, okay? That's not value-based care, okay? And so when you talk about value-based care, well, guess what? Ambulatory facilities, telemedicine are two extreme examples of value-based care. So we're moving into that direction, and now we have a burning platform for it. So what does that mean? It means that you can now evaluate patients for surgery using telemedicine. You know, one of our prominent speakers in the meeting is Dr. Alex Vaccaro, the president and surgeon-in-chief of the Rothman Orthopedic Institute.
Yeah.
And, you know, Alex told me maybe 3 or 4 weeks ago that he now can assess people for back surgery, for spine surgery, by looking at them how they walk at home. And when you think about it, and let's be honest about it, we all learn physical medicine, physical examination at school. I admit it, it's all good, it's all great. In reality, what percentage of your diagnosis do you make today based on only physical examination? Probably not a lot, right? You have imaging modalities, you have function, and so on. So I think that that's why telemedicine is just going to move more in that direction, and you'll see more and more assess before surgery for that, and then move them into the day of surgery to see and assess to take care of them, and the ambulatory surgery centers. So I think we're just going to move big time in there, and people are doing it already. I don't know if you guys have seen the news about HCA today.
No.
So HCA finished the second quarter $400 million higher than last year. $400 million. And when you ask why, you will see that they got from the government $1.2 billion of support. But they also have revamped their surgery dramatically. So what does that teach us? Well, number one is maybe you need to check your own organization when they tell you that they need to pay you less, just to make sure how they're really doing. And two is that it's feasible for everybody to survive, and the government is doing the right thing financially and economically. So I think we're learning how to cope with it, and I am not I don't see doom and gloom for the second wave as far as the hospital industry and medicine. I think we're going to be able to cope with both the disease and our usual business of urgent and elective surgeries.
Well, from your ears, from your mouth to our ears, that would be fantastic, Zeev. In terms of, you mentioned, you touched on the ASCs, and you commented on the telemedicine and the emergence of that. And I remember we did a survey, and it seems that, a small percentage are utilizing telemedicine for new patient visits, but well over 30% are utilizing it for return visits. Talk to us about what you think is in the future with regard to ASCs a little bit more, and also telemedicine. Is this going to stick? What kinds of innovations are we seeing, or changes that you think, you know what, these are efficiencies that came from the pandemic that were good for us and they will stick? Talk to some of those, please.
So two comments. Number one, I loved your comment about virtual medicine and training of residents. And I'm just going to do a plug-in for Justin Barad, who I'm sure some of you guys know, from UCLA, and his virtual platform. He spoke in our conference last year, and it's very cool, right? So it's the way that the future should move into that area. And by the way, I have an Oculus Quest sitting right here, and I'm working out with an Oculus Quest, and I'm like, why is it that I can't train in something with Oculus Quest? It is just so amazing and realistic. Now let's start with telemedicine. I think the percentages are probably higher, Mike. Last week, we had a webinar on telemedicine, and about 50% of the people are using it. I saw some other applications going up to 75%. I think it depends what population you're talking about. I'm also going to say that in our conferences, believe it or not, most of our audience are for private practice. It's not from academia. And I think that's one of the reasons is because private practice is more nimble and more willing to adopt changes and innovation as compared to academia. And don't shoot me because I am from academia, right? Yale at the University of California. So I'm an academician, but that's my view of kind of what's happening. That's the personalities of people. So is it going to stick? It will. What percentage? I think it's harder to say. A lot will depend on the payment system. That's the bottom line, right? So right now, they waived all the out-of-state requirements when you pay, and they pay the same as an in-person visit. If they will adhere to that, I have no doubt that telemedicine will just boom. If they will stop it, it will probably go lower. It will still be there. For example, and my fellows, the surgeons, are much better to talk about this, but within the surgical bundle of payment, there is a post-op visit. Well, the surgeons don't get paid extra for the post-op visit. It's included in the surgical fee. Well, now, instead of bringing the patient to the clinic, they can do a post-op surgical visit at home, right? And everybody's winning from that. The patient doesn't need to travel, and you don't need to waste your time with an infrastructure. So I think some of this will stick. There's absolutely no questions. In my own area, in anesthesiology and perioperative medicine, evaluating patients before surgery, UCLA has a huge telemedicine program right now when you evaluate your patients before surgery. I don't know about your own organizations in HOI or in Miami, if you guys have telemedicine now for preoperative evaluation, but it's phenomenal and you guys should adopt it from that perspective. So I think I'm optimistic, but I think it depends on the payment structure. And that's what I'm worried about right now. I'm honest with you. I don't know if CMS and CMMI will not come back and kind of tweak it and say, well, maybe we'll pay half. And then we're going into the usual, well, do I bring the patient in because from the same service I get paid more or not? We'll have to see. ASCs, I think that this will just accelerate the migration to ASCs. I have no doubt about it. They already, if you look at the volume and you talk to SCA and all the big three, they'll tell you that their volume has increased dramatically. I think patients, my own patients, when I see them in the hospital, they're very anxious. And they have told me multiple times that they would have rather gone to a surgery center if we would have had one. Because there is less of a perception, and quite honestly, they're right. There's no corona departments in an ASC, and you can actually make sure that you're almost corona-free in an ASC. So it's here to stay. It's going to accelerate it. I'm sure everybody has seen the prediction. In orthopedics, 27% increase in the volume at least over the next 4 years in ASC, drop of 3% in inpatient volume. That's before the pandemic. I don't know what the new numbers are, and I don't trust any numbers today. We'll have to wait for a year, but I promise you they're going to be high. So ASC, I'm sure all three of you guys are operating already in ASCs. There's no question about it. And it's its own kitchen, right? We can talk about aesthetic implications and all that stuff. We're not going to do that today. But it's here to stay. And I'm going back to Carter here, is like, it's an amazing platform now to move to things we should have done 5 and 10 years ago, move to ASC and move to telemedicine. And it's happening now.
Zeev, I appreciate that. And to follow up with some of the changes that are being prompted, I remember when COVID first came out, after the first couple of months, we saw private practice taking absolutely draconian steps with gigantic pay cuts, some furloughs and everything else. And I thought what we would see is more consolidation of the employers to where small orthopedic groups would come into bigger, and maybe a migration to system employment sort of thing. How do you see employment models of physicians changing as a result of what's going on? Or is this just the sort of thing where we're going to get through it and it's a blip, we're not going to see major changes longer term? Do you have thoughts on that?
Well, I'm going to give you a couple of examples. Again, I'll start with my own space. So in our space in anesthesiology, there are a number of large national groups, and I'm talking 2,000 to 3,000 anesthesiologists in each group. Well, one of them just offloaded their entire anesthesia division and sold all of them for like something like $30 million, which is peanuts for about 2,000 providers that they moved to the other group. Just nothing, right? So I do think that it is happening. I think that the CARE Act has helped a lot. So I think a lot of practices were able to sustain themselves. I don't see a huge move right now. If the CARE Act will continue, the CARE Act, by the way, there is a posting I did on LinkedIn, guys. There is a link there that you can check every single hospital and provider, how much money they got, not actually providers, hospitals. And it's worthwhile to read because you will realize that everybody got money. And so therefore you did not see a dramatic change in that landscape right now. So I don't predict a dramatic landscape change there. Whatever needed to happen already happened. Not a huge change there. That's it. At least that's the read right now with the private equity market.
I think it's just fascinating, and I'm not sure how these things are going to play out. I want to ask Jonathan or Tabs or Matthew if they have specific questions for you before we ask you to, if there's other things we haven't covered, for you to expound a little bit more on some things that maybe don't tie to a direct question I ask you. Let's start with that and then open up to Jonathan and Tabs and Matthew and others. But what did we not cover that you really want to point out, about this pandemic and how it's going to shape the future for us?
So I just want to go back to value-based care. I started this organization because I believe in breaking the silos. And, again, when I was the Dean of Clinical Operations, I thought everybody works in their own silos and don't communicate. And the result is that the overall result is less good for everyone. So that's why we've started this organization that has everybody in there. And I just strongly believe that if you have on a podcast or a webinar, orthopedic surgeons and anesthesiologists and administrators, the webinar will be that much better than if you just have orthopedic surgeons, to be honest, right? So I just want to say, really, we all need to think that way. And by the way, value equals outcomes divided by cost. So it's not that we need to decrease our cost, it's just we need to increase the outcome, no matter the better, make the outcomes better. So let's just think about it along those lines. And I'll just stop there, and I'm delighted to hear my comments from my colleagues.
Ortho Mentor, thoughts on that or other questions, please?
I jump in and say, I think it's a great talk, Dr. Kane. I think you absolutely hit the nail on the head with a lot of those things. Going off of telemedicine, I think there's a lot of value in telemedicine, and I also have had some trials and tribulations. How much do you foresee technology playing a role? And I guess specifically what I'd say is, do you foresee private investors or maybe even Amazon developing platforms that are almost for subspecialized telemedicine? So there's a telemedicine for orthopedics, there's a telemedicine for the anesthesia side of things, there's a telemedicine for the primary care doctors. I mean, how much do you think that'll really be driven into a subspecialty field, given the nature of our exams being very different? And how much do you think it's going to be driven by private companies, private investors, as opposed to driven by the really healthcare institutions?
Yeah, I can tell you that if you look at that space right now, there are very few public companies in that space. And I will not even mention names because it will come as an endorsement, and their stocks may be priced a bit high, a bit low. I'm not going to go there. There's a huge opportunity, and I get multiple phone calls about this already. There is a huge opportunity in that space. I don't think these systems are optimized at all. I think there is an opportunity for much better telemedicine systems, and there will be specialty specific. You will probably see them in the next 6 to 9 months when they mature. This use of Zoom to see patients, I think it's very problematic. I think that there's a lot of security issues there, and it's very simple, but there's security issues. So I think that will go away at some point unless Zoom will come up with their own platform. So I will say just be patient. People will come up with much better systems. And I hope that they'll start to move more into the 3D area as well. So it's going to be a much better physical exam that you could do somebody than just in front of the camera. I've just no doubt about it. So my advice is just wait, because we have not seen anything yet. It's just really coming in the next 6 to 9 months.
With Dr. Kane, first off, thank you again. I want to echo Jonathan's sentiments as well. That was wonderful to hear. And one of the things, and just to piggyback off what John was asking about, is, do you think the telemedicine and some of the, even just the platform access, you're talking about the Oculus Go, there's, and also VR, and then there's Precision OS that's out there, and then we're obviously talking about telehealth, various platforms that are there. But now there are already disparities to accessing care and medicine. Are we going to further see, in your mind, even greater disparities because of, there's people who don't have a phone, don't have internet access, don't have these various things. So are we, facing another inevitable sort of strain on the system because again, of disparities that we're seeing currently, and even with real-time kind of things?
So number one, healthcare disparities is not an academic, okay? With my other half of my life, or 80% of my life, I do NIH-supported research, and we do now geocoding. And I can tell you that the thing in that field is that the code where a person lives is more important for his health outcomes than the genetic code he or she carries. That's how important where you live is, right? So with that in mind, I appreciate your comment, and I'm going to say the following. I think it's a two-way street. I think that as far as cheap platforms, let's take, again, Zoom as an example of a cheap platform. Everybody almost has right now access to the web, guys. That's just the reality. If you look to the Pew reports, 85, 90% of the US has access to the internet. So I'm going to say that for that population, now instead of taking a bus or a cab they don't have the money for, they can actually just Zoom in. So for low cost media, I'm going to say it's actually better. Now, when you're going to start talking to me about the Oculus Quest parallel of medicine, which the 4 or 5 of us hope will come,
Yeah,
is I agree with, and that is a $500 toy, and so totally agree that there'll be healthcare disparities. But I'm going to say I am an advocate for the lower end because I think that will actually help our patients.
Yeah, it's actually interesting. We did a study recently here at UM because many of my patients were having such difficulty early on in the quarantine with connecting to Zoom, and so it ended up having to just convert it to a phone encounter, et cetera. And we found that over 90% or about 90% of the patients were dissatisfied or satisfied, and if they had prior experience. If they had prior experience with it, they were even more satisfied. But there were about 10% of patients who were just not happy with doing it, and it really is a paradigm shift in terms of appreciating what sort of care mechanism is being is being provided. And so some patients now, even my telehealth numbers have gone down. I still use it because I think it's great for a variety of reasons. But there's so many patients who want to come in and see me, whether they're new patients, or pre-op follow-up or post-op. And again, like, we're trying to incorporate it to increase efficiency, maintain social distance. But I definitely think that obviously there's some barriers to access as well, at least as from what we've seen down here in Miami.
And I appreciate it. And I also think that if I'm a patient, right, and I'm going to see my orthopedic surgeon, do I think psychologically that they'll take better care of me if I meet with them in person and shake their hands and
Right.
look into their eyes?
Yeah.
Right? So I think that there is a big psychological barrier there. I've no question.
Right. Absolutely.
Yeah. Dr. Kane, so also I echo everybody else's sentiments. That was excellent and well spoken. And obviously I expected the highest, and you met the expectations and exceeded. You spoke of urgency before. I really like that comment, because the urgency driving innovation. In some ways, do you think that will drive a more efficient, expedited kind of rollout of these sophisticated or even subspecialized telehealth systems, as opposed to, like, remember the EHR kind of garbage revolution of all these programs coming out, and it's such a hodgepodge and it took forever and they're all so fragmented. Do you anticipate that the telehealth one will roll out more smoothly, I guess?
So I think that if you leave things, generally speaking, to the private sector, it's probably going to have more innovation in it than it comes from the government, right? No reflection of my political views. I think that's just the reality. That's just the way things happen. If you're going to let the powers of the market to drive this, and the pandemic is here for another, I'm going to say at least 6 to 7 to 8 months, it will drive this explosion. That's just my opinion. That's what's going to happen.
Yeah.
I think the EHR story is a really bad story, because with EHR, if you remember, there was a mandate from the government to implement it. And then there were only 3 or 4 companies in the marketplace that were able to meet those very strict criteria. And so innovation basically died, and you came from a billing system to now what we know as the only thing that exists for now.
Yeah.
I hope that will not happen. And so far it's looking good. And so I think that as long as we let organic growth kind of happen in that space, it's going to be much better.
Yeah, those are excellent points. I wanted to get your take on that. The other thing, so I trained out in Philly, so I know the name, obviously, Dr. Vaccaro. My last name's Varichello. People would always confuse me and think that I was his son or something like that. But the interesting comment with that is how he made that comment about how the virtual visit, like doing the physical exam, I went from very closed-minded, I can't get anything from the physical exam from the virtual side, but I became more open-minded with that. The other pearl that I would say, I think at some point we as physicians and surgeons lost the art of actually talking to the patient and getting the history. A lot of times patients will tell you what's wrong. It doesn't always work out that way, but I think at some point we got into this narrowed mindset of, okay, patient comes in, they have an MRI which shows a rotator cuff tear. You go in and you book them for a rotator cuff repair. You don't even talk to them about how their shoulder's doing. So in some ways, this virtual visit has opened up that history component, which has been lost in the shuffle. The history and the physical. So the physical side has kind of died off on this, but I think that it's elevated the history taking component in my experience and what I've noticed.
I agree with you.
Yeah.
There's no question about it. I'm also going to say that it's going to give even more fire to the entire remote monitoring industry that is just trying to bloom, right? Who knows? You may have next to your iPhone, you may have a connector to an ultrasound, a small probe, and you can do. I mean, we do 12 probe ultrasound exam before surgery. Well, guess what? What is a 12 probe? You tell the patient to put it here and here and here, and then you see the picture, right? So there is a huge opportunity in these devices as they connect together, but it has to be connected. It can't be that it's a Zoom on its own, right? Yeah. That's where what Jonathan, what you're talking about will happen, right? When you can connect that device to a peripheral, such as an iPhone, and then see an ultrasound, right? That's the future of these things.
Zeev, I wonder if you might comment on the consumption for medical services and how this pandemic has maybe brought to question that rate. So specifically, during the postponement of elective and all things that were not urgent, people were postponing care. I see you smiling. You know where I'm going with this one. And I would have thought that longer term, people might have realized, because there have been criticisms of orthopedics as a subspecialty I love, but criticisms that 20 to 30% of the procedures that are done in orthopedics are maybe not necessary. Do you think that the postponement and the kinds of things that we're going through right now are going to potentially start to answer this or change the consumption for services? Or do you think that this is really not going to address any of it?
So I better be careful, although I'm the only non-surgeon here, and although it's virtual, so they can't jump on me, so it's good. There is a very interesting book, guys. It's called Freakoeconomics. I don't know if you guys have read it. It was written by somebody who won the Nobel Prize for economics, and he talks about strange statistical phenomena. And in that book, he describes what happens to mortality when doctors go on strike. Guess what happens to mortality when doctors go on strike?
We want to assume it would go up.
Yeah,
it actually goes down.
It does.
It doesn't.
Yeah.
It doesn't. And there is a big discussion and debate over it, if it's true or it's a statistical error. And, they actually bring Israel as an example. I'm, by my accent, obviously was not born in Newport Beach, where I am today. I was born in Israel. And so I was in Israel when there was a strike of the doctors. And I can tell you guys, doctors not really, they said they're striking, but they really kind of did see still patients. So I don't know what the situation really was. And I think we need more studies with that. That said, I'm going to say that we need to look at the data about a year from now, and then we will know whether or not what the outcome is. Honestly, I think it's a perfect study. It's just a perfect study. And I talked actually with Kevin Bozek about this before. I think a year and a half from now, you do a study, you do a longitudinal case control study, and you look at patients who showed up, and then you have a natural history, right? Because in the past, you wouldn't even wait with these patients. Well, now you waited. So now a year and a half later, you see what the outcome is. Did those who waited and didn't do surgery are doing better, or those who operated on do better, and so on? I'm not going to even try and say what the outcome is going to be, guys. I don't know what the outcome is going to be. I'm just going to say there is an interesting opportunity to look at it. And that's just, I'll stop there. Who knows?
Other questions for Dr. Kane before we take final remarks? Well, we want to thank all of our speakers tonight. This is going to be recorded. It's been recorded. We're going to send this out to all 1,000 of our members. Approximately 400 of those are residents. And I know that the constituencies that follow our groups, Ortho Mentor, as well as the American College of Perioperative Medicine, are going to be very, very delighted to listen to this recording. And I want to thank all of our speakers tonight so much for their generosity and coming in from multiple coasts here to provide education and some insights for all of us. Thank you all very much. Thank you for tuning in, and have a great evening. Goodbye.
Right. Yeah.
Thank you.